Hi, everyone, and welcome to week 6. We've covered a lot of ground so far in this lab: engagement, reflective listening, mental status, screening tools, and now we're turning toward what happens when clients are ready or not quite ready to make a change. Today, we'll focus on three interconnected areas: motivational interviewing, or MI, the stages of change, or trans theoretical model, and how to translate client values into goals, objectives, and treatment plans. These are tools you'll use again and again in your social work practice, especially when clients are feeling stuck, ambivalent, or uncertain about change. Here's what we'll explore together: what motivational interviewing is and is not, how to use the ORS framework to support client autonomy, understanding ambivalence through the lens of the stages of change, connecting client values to goals, and differentiating between goals and objectives in treatment planning and why that matters. Motivational interviewing is a client centered directive method for enhancing intrinsic motivation to change by exploring and resolving ambivalence. It's rooted in empathy, collaboration, and respect for your client's autonomy. In MI, you're not convincing someone to change. You're partnering with them to explore what they want and what's getting in the way. Here's a helpful metaphor. Effective MI should feel like a dance. You're attuned to the client's rhythm, you're guiding gently, you're not pushing. Ineffective MI feels more like a wrestling match. You're trying to force change, take control, or win the direction of a conversation. Clients often come to treatment with mixed feelings, especially when change is hard, scary, or connected to painful experiences. MI helps you respond to that ambivalence without jumping into persuading or problem solving too quickly. You'll have a chance this week to observe a brief MI demonstration and reflect on what makes it effective or not effective. Here are some prompts to keep in mind. Where did the social worker reflect back rather than give advice? Did the client feel heard or corrected? Was the social worker listening for change talk, those small statements of desire, ability, or intention? Start building your ear for these subtleties. MI lives in the details. The ORS acronym is one of the core skills in MI. O is open ended questions, A, affirmations, R, reflective listening, and S, summarizing. Together, these create a space for clients to explore, reflect, and eventually identify their own motivations for behavioral change. Let's break these down briefly. Open ended questions invite exploration. What concerns do you have about your drinking? Instead of, do you think your drinking is a problem? Affirmations recognize the client's strengths and efforts. You've been really thoughtful about how this is affecting your family. Reflective listening builds connection and shows understanding. It sounds like part of you wants to stop, but another part isn't quite ready yet. Summarizing helps organize the conversation and highlight what matters. So far, I've heard you say that you're frustrated with how things are, but you're also afraid of what change might look like. Did I get that right? This week, you'll practice using ORS in triads. One person will be the social worker, practicing ORS and avoiding advice giving. One person will be the client, considering a possible change but not yet committed to it. And the third person is the observer, watching for the use of ORS and noticing any moments where advice giving or fixing sneaks in. Try to stay in the discomfort of ambivalence without rushing to resolve clients' problems. This is where real insight often emerges. Now, let's look at a model that pairs beautifully with MI, the stages of change or trans theoretical model, developed by Prochaska and DiClemente. You'll see this used in addictions work, health promotion, and even organizational change. The stages are pre-contemplation, where the person doesn't see a problem; contemplation, where they're starting to think about change, but they're not ready yet; preparation, where they recognize a problem and they're intending to take action about it soon; action, when they're actively working on behavior change; maintenance, where they're sustaining the change and trying to prevent relapse into old patterns of behavior; and then relapse, which is a return to old patterns of behavior, which is not seen as a failure, but as part of the process. That's really important. In the stages of change model, that relapse step is not seen as failure. It's just part of the process. Any human's progress is not linear. We don't get better and better and better and better and better. We get better and then we backslide. And we try again and then we backslide. This is the process of change for everybody. In supervision or documentation, you might hear, oh, the client is still in pre-contemplation, or she's in preparation and wants to cut back starting next week. This model will help you meet clients where they are instead of where you think they should be, and it keeps you from skipping ahead to solutions when someone's still trying to decide whether change is worth it. Let's shift now toward values, because often the motivation for change isn't in the problem, it's in what matters to the client. This week, you'll use a values sort card to help clients or your simulated partner identify what's most important to them: family, honesty, creativity, financial stability, whatever shows up. Then you'll connect those values to the client's current concerns. For example, a client might say they value health but feel stuck around quitting smoking. Or they might value independence but need help managing daily routines. MI helps explore the tension between values and behavior without judgment. After the card sort, you'll return to your earlier role play and ask, what values did your client express, explicitly or implicitly? What did they say to tip you off? How can you use those values to support goal setting? Values help us hold the client's why, and that becomes an anchor for collaborative change. Let's make a quick distinction now between goals and objectives in a client's treatment plan. A goal is a desired outcome. It's where the client wants to go. The treatment plan is the map. It includes goals, which are the client's destination, and objectives, or the specific steps or route that we'll take to help the client achieve their goals and arrive at their destination. Both goals and objectives should be flexible, measurable, and co-created with the client. For example, if the client's goal is to reduce anxiety, the treatment plan interventions might include things like grounding techniques, relaxation training, and cognitive retraining to help clients avoid cognitive distortions like catastrophizing or all or nothing thinking. This week, you'll practice drafting SMART goals. SMART goals are specific, measurable, achievable, realistic, and time specific. Remember, goals should always reflect the client's language and priorities, not your agenda, but theirs. This week is rich with practice opportunities, and I encourage you to be patient with yourself as you build comfort with OARs, the stages of change, and collaborative planning. Motivational interviewing isn't about having the perfect question. It's about staying with the client even when they're unsure of their next steps. The more you practice, the more natural it will feel. As always, take your time with the module materials, post your questions in the forum, and reach out to me directly if you need anything. See you next time.